I'm Manoj Karmakar. Welcome to ISSPS TV. I trust you are well wherever you are in this wonderful world. Next video, Dr. Kenneth Sheah from Singapore is going to discuss with us the pathophysiology of the difficult spine or central neuraxial blocks. If you like any of our videos, do remember to share and like these videos. If you are new to our channel, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
This lecture is actually prepared by my esteemed colleague, Dr. Edmund So. And he presented this in the previous ISSPS meeting. So it falls upon my shoulders to present his lecture for him. So there are a few things that we need to understand with a difficult spine. The most common one that we will encounter is going to be the degenerate spine. And then following that, we're going to talk about a case of inflammatory conditions in the spine, such as ankylosing spondylitis. And then we'll cover a little bit about other miscellaneous conditions like epidural, lipomatosis, and scoliosis as well. So the most common one that we will encounter is going to be the degenerative spine. And in the degenerative spine, basically there are two things that will affect us when we do paravertebral sonography. The first is extra calcifications, and the second is reduced joint spaces. This would include reduction in the size of the facet joints if we're doing facet joint injections, which then may necessitate us to perform it as perifacetal injections rather than intra-articular per se. And also it will reduce the size of the interlaminar space because of the calcifications. There are a few distributions which we need to be careful about. These include supraspinal ossifications, interspinous ligaments, calcifications, and calcifications in the facet joints. So for example, let's look here at an X-ray of the thoracolumbar junction. Here you have spinous processes, which you can clearly see, and the supraspinous ligaments which traverse the spinous processes demonstrate partial calcification. Now, although we may not see calcification on X-ray, just a word of caution, when you do an ultrasound, don't be surprised if there is actual early calcification as well. And sometimes the ultrasound is actually a bit more sensitive than X-rays, surprisingly, in picking up calcifications. So it's always useful to have these images on a light box next to you as you're going to perform this on a difficult patient. It's better to be forewarned. And if you look here, that calcification in the interspinous space will definitely get in the way of the ultrasound beam and will also interfere with counting of the levels as well. So when you encounter a patient like this where there is supraspinous calcification, how do you count the levels? Look for the transverse processes. That's one useful tip because the echogenic tip of the transverse processes can sometimes be seen and will help you to count. If you lose track of that, you can then turn your probe in a longitudinally, orientate that with respect to the spine, and sweep laterally until you see the trident sign. And once you see the trident sign, that will help you because those the tips of the transverse processes present themselves as the tips of the trident, which Manoj may has shown us in lecture 1. Here's a CT scan of supraspinous calcification, and the CT will be more sensitive in picking up calcifications. This patient had a prior vertebral plasty in a vertebral compression fracture. But you can see here calcification along the supraspinous ligament in the upper part of the lumbar spine. and that will make it difficult to assess as well. Supraspinous ossification can also occur in the region of the sacrum. And you can look here if you're doing a sacral epidural, as well as if you can identify the sacral hiatus, that will be good. But the egress of the needle into the epidural space will be difficult, because you can appreciate how narrowed down the central canal within the sacrum is at this level due to the calcifications. The other thing that you also get is narrowing of the interspinous distances. With collapse in disc space, the spaces between the vertebral bodies will reduce, and together with that, the spaces between the spinous processes will also reduce. And when you do an ultrasound scan, that makes it very difficult in terms of identifying, number one, the spinous processes, but number two, the interlaminar spaces, which will also follow suit and be reduced. We see this most often in the context of a degenerative spine at L4, L5, and L5S1 levels. Here again, calcifications and loss of joint space at the interspinous joints itself. And when you look at that corresponding MRI, you see these bright signal areas here. These represent bursal effusions, so interspinous bursal effusions. Unfortunately, on ultrasound, it's very difficult to identify these bursal effusions because they're really deep and blocked somewhat by the interspinous ligaments themselves. The other thing that you can encounter with reduced interspinous spaces is also the presence of these cystic structures. These are synovial cysts arising likely from the facet joints itself, and they arise posteriorly and encroach on the epidural space. So looking at the T1 weighted images on this side, we have an appreciation of the epidural fat slightly higher up at L2, L3, and L3, L4 levels. This is about 5 to 6 millimeters of depth, epidural fat depth in the midline. But once you come down to L4, L5, there's almost no epidural space left. And this is a big cyst sitting and encroaching on that space itself. Interestingly, at L5S1, you do see reappearance of that epidural fat again. And this allows perhaps an interlaminar approach into the epidural space at L5S1. But you could easily imagine a scenario where the facet joint synovial cyst was at L5S1, and that would block your access completely. In this patient, there's also anterior listhesis of L5 relative to S1. You can see a step here, and sometimes that can be related to pars interarticularis fracture or just ligamentous laxity resulting in listhesis. Now, the presence of a listhesis usually doesn't cause very much problems for us when we do ultrasound guided blocks. We can, because we're looking for the spaces, the interlaminar space, for example, and they don't really pose that much of a problem unless you start to hit grade 2 to grade 3 spondylolisthesis. But usually the grade 1s are okay. So this slide is just another 3D CT just to demonstrate the narrowing of the intervertebral disc spaces at L3, L4, and L4, L5 levels with calcifications and osteophytes as well. And so once you have loss of intervertebral disc height, you will have loss of interspinous spaces. Here, another example of calcification in the interspinous spaces themselves. And this you will encounter as your needle traverses in the midline, for example, if you're doing a midline epidural. Once your needle goes beyond the tip of the spinous process, you can sometimes lose track of it. And then if you're depending on the loss of resistance, you start to encounter these areas of calcifications within the interspinous ligaments. And these can actually give you a false feeling, a tactile feeling that you may have either gone through the ligamental flavum, for example, or you are hitting against bone. So if you're at this level, again, look out for these calcifications, because you don't really want to insert your needle at this level and encounter calcifications here. They get in the way of a smooth needle egress into the space. So you'll have to then choose another level which is more suitable. Now, the other thing with degenerative spine, when you have loss of intervertebral disc spaces, is that then a lot of the weight is then transferred to the facet joints. And when the facet joints are subject to wear and tear, the cartilage layers are lost, and then you start to have bone-on-bone contact. And that may sometimes obliterate the joint space. And it's also accompanied by the presence of large osteophytes, which then, number one, distort the image on ultrasound, but number two, distort the needle approach into the facet joint. So here's a cross-sectional image again. Now, not all our patients will have ready CT spine images, which are so pretty. But if you go through your hospital records, you sometimes find CT scans of the thorax performed for these patients, or CT of the abdomen and pelvis, and these will have adequate data for you to reconstruct back into a CT of the lumbar spine. So just go downstairs to your radiology department, and they should be able to generate for you some images of the lumbar spine in 3D. If you've only got the axial images, you can still see that. Just change the windows of your viewing windows to bone windows like this, where all the soft tissue becomes a bit more gray, and you've got more focus on the bones themselves. Now, looking here at the facet joints at this level, for example, you can see how the facet joint anatomy has been distorted. Here, it's relatively preserved, but the right facet joint demonstrates osteophyte formation, and then it's also hypertrophy. There's also less loss of joint space, and also loss of the normal fluid signal within the facet joints themselves. And if you look here, there is a bit of a lip for you to park a small 22 gauge needle into the joint space. But here there's no fish mouth appearance to the facet joint. And with these cases, sometimes you have to admit defeat and perform a perifacetal injection. Facet joint cysts, I've shown you a example previously. They can occur within the spinal canal and result in spinal canal narrowing. They can distort the epidural fat. They can also be seen externally. Usually, the externally located facet joint synovial cysts are not of much concern because they don't cause very much problems with the neural structures, and they can be left alone. So that's with degenerative spine. We now talk about scoliosis, and Manoj will show you an example of ultrasound-guided neural axis blocks in a scoliotic patient. There are really, again, two things with scoliotic patients that will distort the anatomy for us. Firstly, you have a lateral curvature of the spine. Depending on how severe the scoliosis is, it can be quite severe, and it can be accompanied by vertebral rotation around the long axis. Here's an X-ray of a scoliotic spine. The convexity is to the right here, and there's a secondary curve convex to the left at the thoracolumbar junction. So if we look here at the thoracolumbar junction, in this patient who is relatively young, there's not much osteophyte formation, not much degenerative change. You can still see the interlaminar spaces quite nicely, the pedicles and the facet joints on the X-ray. And at least these images will help you with your planning. So for example, if you were to perform a central neural axis block on this patient, then you would know to try and angulate your probe accordingly along the axis of the scoliosis. So another one, a patient with a CT scan here. This is in the lower thoracic spine. You're starting to see the appearance of the liver. And you can see how much the ribs sort of get in the way and reduce that space between the transverse process, the ribs, as well as the spinous processes. So on the compressive side of the scoliosis, you're going to have much less space to work with as opposed to the convex side of the scoliotic spine. And this needs to be taken into consideration. The vertebral body is also rotated around the central axis, and this will be another confounding factor as you search for the midline. And in this sort of situation, it's always worthwhile when you're doing your procedural ultrasound to map out the tips of the spinous processes with a skin marker. So at least you know roughly where you are going. Another CT scan showing you how severely the lateral convexity can be in these cases associated with vertebral rotation as well. And in this patient with long-standing scoliosis and combined osteophyte formation around the intervertebral discs, you can imagine that the interspinous spaces are also going to be severely narrowed down. Another condition where we have a lot of dystrophic calcification is in the inflammatory conditions, inflammatory spondyloarthropathies of the spine. These include rheumatic diseases, such as ankylosing spondylitis, reactive arthropathies, psoriatic arthritis, and other spondyloarthropathies as well. The main thing, then the uniting factor, is that there is dystrophic calcification in all these cases. Now, for ankylosing spondylitis, the main thing that we have to remember is that the intervertebral disc heights are usually preserved. But then the problem then comes is that you have calcifications, ossifications, and antisophyte formation flowing along the longitudinal ligaments, the anterior, the posterior, and also the interspinous and the supraspinous ligaments. And these new bone formation result sometimes in bone bridging when they're advanced. And again, they can attenuate the ultrasound beam. They can get in the way of labeling of the spinous processes as well. You can appreciate why they call this a bamboo spine now on the CT scan. The disc spaces are obliterated. They're almost calcified completely through, except for this appearance of this bamboo-like appearance of the spine. A lot of bone bridging. In psoriatic arthropathies, you get enhancement with contrast-enhanced MRI of the interspinous and the supraspinous ligaments. Eventually, these can calcify up as well. The other thing that's important is that if you have enhancement here in the interspinous spaces, it's not advisable to pass a needle through it because then the number one, you're not sure if it's infection. And also number two, they can be very painful as you pass a needle through these areas of inflammation. So that's with spondyloarthropathies. The main thing is formation of new bone and calcification of the ligaments. Another condition where you get abnormal calcification in the body is in patients with prior history of injury to particular areas resulting in heterotopic ossification. Firstly, these can appear quite aggressive and may be confused for tumor in some cases, so they will require some degree of workup. But if you look at the CT scan here, this is an example of a heterotopic calcification. It's smooth. There's no interrupted periosteal reaction. There's no large soft tissue component. There's no erosion of the underlying bone. And usually there's a history of trauma from months before or years before. But once again, you can imagine that if you've got an ultrasound probe coming up here, you'll suddenly see this calcification appearing. And then you'll be confounded because it's more superficial than the tip of the spinous process. So this is something that you need to be aware of if you have prior imaging. Another condition, which I warned you guys about when we were talking about the lumbar spine, is that when you assess the lumbar spine, don't ignore the T1 weighted images. Those are really important for evaluation of the degree of epidural fat. Now, the epidural fat is our friend when we're doing lumbar neural axis blocks, and also relevant for epidural injections. In some cases where there is obesity or a history of steroid use, chronic steroid use, these patients can present asymptomatically with epidural lipomatosis. So what's going to happen is that you place the needle in a paramedian parasagittal approach. You think that you're into the epidural space, but when you perform your injection, it doesn't flow around the thecal sac because of the proliferation of fat around the thecal sac itself. So this is the problem of epidural lipomatosis. It retards the flow of the epidural injectate. So how do we appreciate this? Again, look at the T1 weighted image. The T1 weighted image usually has dark signal for the CSF around the spinal cord, but bright signal for fat. So this is the subcutaneous fat that's normal and bright. As you come in, you're looking for that epidural fat layer, which will be our protection when we perform injections. And then if you look at a patient with epidural lipomatosis, that fat layer is thickened. So this is thicker than normal. And sometimes it can encroach on the spinal cord itself. So there's been some work performed about doing 3D computed tomography, CT scans essentially, for difficult thoracic epidural needle placement. And they show that the number of attempts would increase as the interlaminous places were occluded. But you can get CT reconstructions readily available from prior CT scan studies if you have access to the hospital records. And I would advise you to make use of those when you're doing your pre-procedural planning. So in summary, you should be able to access some degree of imaging for your patients from previous studies. Get hold of those if you anticipate a difficult procedure. CT with 3D reconstructions are very good if you require assessment of calcifications, because they demonstrate bony anatomy very well, and they demonstrate calcifications in the ligaments very well. When you perform MRI, they are good for soft tissues, but in our case, the main evaluation is for the epidural space. It gives us a gauge of how much space we have, working space we have when we perform our blocks, and gives us a good overall view of the anatomy. With that, I conclude this presentation.